So our agenda for this evening is quite brief, but it will be really interesting. Really looking forward to hearing the presentation this evening. Dr. Vallings is going to talk about COVID, which obviously has been the hot topic for the past year, and I know it's also been a really hot topic within the MECFS community too, in lots of different ways. She'll also give some details about her new book, and then we'll have some Q&A if anybody's got any questions. So I'd like to extend a huge thank you to Foundation North, one of our funders who really make it possible for us to deliver services to people with MECFS, and we couldn't do it without our funders, so thank you, Foundation North. Also thank you to our wonderful board. Most of us are here this evening. If our board could just put their hands up, and then maybe people who are here can see who they are. If anybody would like to chat to our board, then they're kind of sitting along the back there. Also our support workers, and Natalie, who's here this evening, and Megan, who couldn't be here tonight. She had a bit of a cold, so thought it wasn't wise to come and share that with everybody. And then New Zealand Manukau for this wonderful venue that we have here tonight too. So, Dr. Vallings, really delighted to welcome Dr. Vallings, who's a distinguished medical practitioner specialising in MECFS. I think most of you probably heard of her. She's actually had a medical practice in Auckland since 1966, so she's been doing this a very, very long time and has a real wealth of knowledge. She's attended many seminars, as a speaker, at many seminars and conferences, both in New Zealand and internationally, and she's been involved with GP and student education at the University of Auckland. And she's written 2 books, or is it 3 now? I think it's 3 with the new one, isn't it? She's a medical advisor to ANZMEs, which is the national organisation that supports people with MECFS in New Zealand, as well as a member of the International Association for CFS-ME. In 2008, Dr. Vallings was awarded the membership of New Zealand Order of Merit for services to CFS-ME in the Queen's New Year's Honours, and that's a huge honour for somebody in our community. As well as 2016, she was awarded the Nelson Gantz Outstanding Clinician Award by the International Association for CFS-ME at their biannual conference. So, wonderful. Welcome, Dr. Vallings. We're looking forward to your presentation.
Sorry, I'm wired up like a pop star, and I won't sing, but can you all hear? Oops. It's not too echoey or anything? No. Well, anyway, you're all right. I've got a thumbs up at the back, so it must be all right. Maybe when I move around, the sound might do funny things. We'll see. Yeah, I've got this right. Oh, dear, I've gone too quickly. Oh, my God. Right, so we're doing a research update, and I'll go through that reasonably rapidly. There's an awful lot of research out there being done now, as you're probably aware, all around the world. And I'm going to go through that, and then we'll talk a little bit about COVID and the COVID vaccine, because I think it's the COVID vaccination issue that's particularly relevant to people with this illness. And we'll have hopefully time for questions at the end. Is the sound all right? Really? Is that better? It's a bit echoey, isn't it? Is that better? Yeah, everyone's nodding, so it must be better. Okay, so where are we at? Well, certainly, I mean, our lives are at the moment dominated by COVID, and there are, these so-called long-haul people, which are, I mean, it's exactly the same as MECFS, really, isn't it? And, of course, it's going to lead to a greater awareness, and there have been articles already about long-haul COVID and its relationship to ME in the JAMA, which is the Journal of the American Medical Association. And they said, this big headline, long haulers stump the experts. And this is not that long ago, so they're working on it. Dr. Mady Hornig is one of the CFS leading researchers, an American woman. I've heard her speak several times, a brilliant woman. She's actually had COVID and is hopefully coming out of it, but she's rather fearful. She's got the long haul, but she's kind of, looking after herself and hopefully coming right. But I think more importantly, despite all this, it's going to generate a lot of money going into research. Oops, I've already gone too fast. So there's a lot of money there. I won't leave that up for long, but Nancy Climers, who you probably heard of, her group has received $4 million initially, $1 billion from the Centre for Diseases Control in America to study the long-haul implications. And even Professor Tate down in Dunedin, who you may have heard speak yesterday. Did any of you hear him yesterday? He speaks very well. He was on Radio New Zealand. He's been given $60,000 to compare long-haul COVID with his group of MECFS patients. Most of his research now is in CFS. He's a professor of biochemistry down there, for those of you that don't know, and he has had, a few years ago, New Zealand's highest scientific award, which was the Rutherford Medal. So he's a very highly thought of scientist. Just to run through, I went to the IACFS Conference last year, which was held in New York and California, sort of oscillating. You may think, well, how did she ever get to that? Well, it was online, and it was at 2:30 in the morning we started, and it went on and on and on. And my daughter, who's a doctor, who's also very interested in this illness, she watched it with me. And it was really great, actually, to be able to go. And if any of you want the report, that's the website, and I think you'll have these slides so people are interested, won't you? Just a few points of interest from the conference. There was a whole segment on the likely effects of COVID. This was back last August, so you can imagine, that by now there would have been a lot of research moving on that. And then they had a treatment session, and it was interesting. The Japanese, they present at these conferences, and the Japanese research we don't normally hear much about, but it is moving on and on. They've always been very much into the science of this illness. They had Professor Kurotsoni from Tokyo, and he's very well known in the scientific world, and he's been a major researcher in Japan. Anyway, they talked about the importance of how we need to really understand the science of this illness before we can really launch properly into treatment. And I think that's something that we all fully understand. There was a self-management group from America. They showed that people who learnt a lot about the illness and managed their lives sensibly, according to the level of illness they got, did very well. The people who didn't know much about the illness and managed it all wrong, of course, didn't do so well. I suppose it's obvious, but it was a kind of proper study, a proper scientific study. They also found that visiting patients who are very severely housebound, these were nursing people who went out into the community, again made a huge difference to their improvement in health. People who are abandoned and hidden away in a darkened room with no real medical contact didn't do nearly so well. There's quite a lot about low-dose naltrexone, which I know probably several of you here have possibly tried or be interested in trying, and we can talk a little bit about that later on, but it's one of the kind of buzzwords at the moment, and symptom relief in this particular study for 73%, which is a high percentage. It's not curing the illness by any means, but it's giving some real benefit to some people. And then there was another, I'm only picking out some of the papers, the studies, the ones that were interesting. A really interesting one on what we call oral rehydration, and this is making sure that you keep your fluids up, but accompanied by salt in particular. So some of these sports drinks, energy drinks, have been shown to be helpful. But this particular study showed that it wasn't just salt and water that people need with this illness, which we've known for a long time, really important to keep your salt intake up, but the salt is better utilised if it's accompanied by glucose or sugar in some way. So a combination of a salty drink with some sugar in it, which a lot of these prescribed electrolyte solutions or sports drinks have anyway, or having something sweet to eat, sweet things over there, accompanied by your more salty, savoury food. So that was really quite important. It improved brain blood flow quite noticeably. Then there was a whole section on diagnosis, and some of you will have had a tilt table test or heard about tilt table testing and wondered if they could have it done. And there are tilt tables now at some of the cardiologists here in Auckland. They have them at Green Lane and some of the private cardiologists. And this is to diagnose whether you suffer from what's known as POTS, which is postural orthostatic tachycardia syndrome, which means, in simple terms, if you get up suddenly, you feel really woozy and lightheaded. And this diagnosis is quite important because the treatment of it can be quite successful. It goes hand in hand, both genetically and day to day with people who have chronic fatigue syndrome. The so-called tilt table test, very expensive and hard to find. You might be lucky if you're in a big centre like Auckland, but there's a so-called lean test where you get your patient to lean at a sort of bit of an angle against the wall. It must be quite difficult, but you do it for sort of 5 minutes or so, and then you check their pulse and blood pressure and see if there have been changes. And this can give you a fairly clear diagnosis of this illness. And Dr. Lucinda Bateman, who's in Utah, she's again another of the sort of gurus in this illness. She has got a sheet of guidelines which you can get from the internet. There was also a lot more talk about the metabolism. We know for sure that and Professor Tate's work has proven this, there's been a lot of changes in the body chemistry in this illness, and the so-called metabolites, which are all the thousands and thousands of chemicals acting all the time in your body at daytime and nighttime. They're all very different in this illness. All sorts of, they looked at 660 metabolites and found 159 of them were quite abnormal in this illness. So that's very significant. And it's likened to animals that hibernate. So it's very similar to the body changes that are occurring when an animal is in hibernation. So maybe that's what's happening to a lot of you, crawl into a hole and you might do quite nicely. And they also found that healthy muscle cells that were put into the serum, which is the sort of watery component of your blood, the healthy muscle cells put into CFS serum in the laboratory, of course not in the body, these healthy cells changed and they didn't work as well. The so-called mitochondria, which are the little powerhouses, worked in a very abnormal way and produced a lot of the chemical called lactate, which causes muscle pain and muscle cramping. So these tests were kind of useful. The UK situation, they had people from Britain. For them, the timing of day was a little easier than the Kiwis and the Australians. But they produced quite a lot of talk about their work and the effects of COVID and all this kind of thing. And again, there's a website you can go into because they've got a really good research brochure for people who need more information or who are interested enough to get information. Their so-called annual conference in London, which I've been to 11 of the 12 now over the years, had to be cancelled because of COVID. they've rescheduled it for next year, but I got a notification yesterday that that's going to be online too, so that'll be all nice as well, so because I want to go. The UK research, well, again, I won't spend a lot of time on this, but they said, yes, it's definitely shown now to be a multisystem disease with definite genetic changes and predispositions. So you're born with the genes that make you prone to this, but you don't necessarily get the illness because of that, but you are prone or vulnerable to getting it. And people worry, of course, will I pass this on to my children? And the risk of passing it on is actually quite small. You have to have 8 children and only 1 is likely to inherit that vulnerability gene. So I don't know how many here have got 8 children, but, well, most of us haven't, but you never know which of the 8 it's going to be. But that's just statistics, really. So-called comorbidities are common. This is things like POTS and fibromyalgia, and a number of other medical conditions that seem to frequently go hand in hand: migraine, endometriosis, irritable bowel, and so on. There's definitely been shown now without doubt to be changes in the immune system, and the metabolome, which is the metabolic stuff I've just mentioned, and the microbiome, which is all the bugs that travel around in your gut, many trillions of bugs there, and apparently now they know that your gut has got more of the immune system in it than any other part of your body. And then there's abnormalities in the mitochondria, which are the little powerhouses in the muscles, muscle cells, or every cell, but particularly the muscle cells abnormal in this illness, and lots of changes in the brain and the neurological symptoms. So a lot of people with this illness get lots of neurological symptoms like shooting pains and tinnitus and eye sensitivity and you name it, you know, lots of cramps and things. The Australian research, well, probably that might be a bit of double Dutch to you because it is to me too, but the Australian team at Griffith University in Queensland are really up with the play. They're a very ahead team. The Queensland government, I think, gave them $12 million last year to carry on. It's an incredible research laboratory, but they have found, you don't need to understand this because I'll simplify it, they found that the way calcium moves in and out of cells, and that happens in every cell in your body, is quite abnormal due to this very strange TRPM3 receptor. So calcium is moving in and out in an abnormal way. You can't change that by either having more or less calcium. It's nothing to do with what you eat in the way of calcium, just the way that that aspect of your body works. But what they have found is a very real abnormality that seems to be quite characteristic of this illness, so may eventually be the one thing that everyone's waiting for, which is the lab test to prove that I've got it. This sort of thing is coming at me all the time, people asking how long it's going to be. Unfortunately, this test is not easy. It's a very, very complex business in a very expensive specialised laboratory. But you know, once you've got the start of something, coupled with, let's say, some of Professor Tate's work in Otago, which is also equally important, you may find that these centres can come together with something that's a little bit more simplified. What they have found, however, and they're doing studies now, is that the low-dose naltrexone, which is the LDN at the bottom there, may well help to correct this abnormality, and that's possibly how and why it's helping 73% of people who take it. We don't really know the answer. What about New Zealand research? Well, Professor Tate has published 2 articles recently, both of which have hit the world medical headlines, which, you know, is quite exciting for little New Zealand. But he's working with a team and in the field of epigenetics, which is the way genes work. Genetics is the genes we inherit and what they're for. Epigenetics is the way they work. So his study has found that certain cells in your blood have actually shown very definite dysfunction of these so-called mitochondria, which are the little powerhouses, and further studies looking at, well, DNA methylation. Don't ask me what it is, I wouldn't be able to tell you. But that is giving them very, very clear distinction from the healthy people that they are testing. So this is a definite yes-no answer. Again, he hit the world headlines about 6 weeks ago. Very, very excited medically around the world by these findings. So, we should be justly proud, but also very, very excited. Then there was quite a lot of talk at the conference, and also I've added into it a bit because people are always interested to know, what about medication? What can I take? What might work? What might help? And this is basically a list of medications that I've sort of gathered together from various sources, including quite a lot from that conference in America just recently. I'm not going to go into a lot of detail, but just to show you there's lots of possibilities. Hormones, we know for sure more women than men get this illness, and it's thought highly likely that there is a hormonal component. And many women do extremely well on estrogen. I had a 14-year-old today who came to see me who'd been put on the pill by her doctor, and she's almost coming out of her CFS, having been ill for about 5 years. So, there can be quite dramatic changes sometimes with things that we try. Fludrocortisone is a drug that helps your body retain the salt, and that's another very important abnormality in this illness, that the salt does seem to just go. Psychological things, really important not to shrug off. Antidepressants, then there's Ritalin, which is a stimulant, sertraline, a newer antidepressant, and it's really important to treat depression because depression drags you down further and slows down any potential recovery. And I always say to people with this illness, you'd be very abnormal if you didn't get depressed from time to time with this illness, so don't deny it. If you do start feeling down and depressed or really stressed, do seek help. Anti-epileptics are used a lot for pain management, and that might seem a bit strange, but if you understand anything about epilepsy at all, it's due to abnormal firing off of electricity through your nervous system. That's very simplified, but you kind of get a clue from that. And a lot of the acute and the more chronic pain associated with this illness is due to sort of malfunction in the electrical processes in the central nervous system. So anti-epileptics can be helpful, and a lot of people will have tried some of those. Drugs for the heart, there's nimodipine, which improves brain blood flow, propranolol and midodrine, which slow down the racy heart that a lot of people get with this. So again, we use these things for symptoms. Low-dose naltrexone, I've mentioned already a couple of times, getting quite popular as something to try. The other thing it's been found to do is to quieten some of the sort of sparkly inflammation in the brain that they see on some of these very specialised brain scans they're doing now, so-called glial cells in the brain, which kind of sparkle on these scans, and the low-dose naltrexone quietens down that inflammation. And another neurological drug, pyridostigmine, is used to treat various other neurological illnesses, and that's certainly being used. Ropinirole, another one for restless leg syndrome. Then things for sleep. The one in the middle, the amitriptyline, is the one that we would tend to say is the most likely and important drug in this illness to help get sleep right, because if you don't have a good sleep, you are not getting the release of hormones and chemicals that have a healing effect on your body. and therefore you don't begin to get better and heal. So amitriptyline is one of the few drugs that does give you back a more normalised sleep pattern. It takes about 2 weeks to work, and it has to be taken about 5 hours before bedtime, and we use a minuscule dose. So, these things shouldn't be sort of, oh, I don't want anything like that, because they can be very, very important. Muscle relaxants, those are important too, sometimes for sleep management or pain management. We use antivirals quite often. I had a ME patient again today, and he came in, told me he'd been on this antiviral, which I prescribed for him 11 years ago, and he's still on it because every time he stops it, all his symptoms come back. So I don't know why, and nor does he. But, there are people with this illness whose whole underlying mechanism we don't fully understand. Spironolactone is an interesting drug because that is used as what we call a diuretic to get rid of excess body fluid. But Dr. Dan Peterson in Klein Valley in Nevada, who's another of the CFS leading lights in the medical world, he has found that spironolactone actually has a lot of antiviral properties. So, it could have a double benefit for some people. Chemotherapy, I'm not going to go into a lot now, except to say that the Norwegians are the leaders in this, and some of the cancer drugs are being trialled with some success. I don't know what the latest outcome of this cyclophosphamide is, but they are hopeful that it could be very helpful in this illness. Isoprinosine quietens the immune system down. Very expensive, but you can get it here. It only works in about 1 in 4 people. You have to be on it for 6 months to know if it's going to work. So you're spending a lot of money for something that may not work. So that's a bit of a worry. But this bottom thing is really interesting. Suriname, you might be able to see it properly at the back, but that's a drug that's used to treat, or used to be used to treat sleeping sickness, which is an African tropical disease caused by the tsetse fly. And they've largely got rid of that drug now because they've got more modern things that settle this particular illness down, and it's not so prevalent as it used to be. But Dr. Ron Davis, Professor Ron Davis in America, whose name might be familiar to some of you, he's again a very well-respected biochemist. He is trying to resurrect this drug and get them to start manufacturing it again, because he says it's got a lot of potential for people with chronic fatigue syndrome. So that'll be an interesting one to see. I'll move on. And then this issue with leptin. Now, Marianne Fletcher is a person who is quite elderly now, and she was the doctor, she's in Florida, she was the doctor who discovered the test for glandular fever. So, she's a really, really important researcher. She would play it down completely. She's just an ordinary person like you and I, but she's a very, very famous, well-respected person. But her last 30 or 40 years of research has gone into chronic fatigue syndrome, and so she's still working in this field, and she's working particularly with leptin, which is a chemical your body produces, and she thinks again it could be incorporated as possibly a test for this illness, because the leptin levels are quite way out apparently in this illness. It's particularly associated with obesity and with stress, so you produce lots of it if you're either obese and or stressed, and so to lower the levels of leptin, which certainly helps people with chronic fatigue syndrome quite a lot, you need to be thinking of stress management, meditation, dealing with your stresses and so on, and also losing weight. Now, I know losing weight's easier said than done, and I'd be really wealthy if I'd found the cure for that one. Haven't found the cure for weight loss yet, but in this illness, losing weight and meditating can be quite helpful. For again, they're areas to explore, aren't they really? Also, she's found that the LDN, the low-dose naltrexone, the antiviral valganciclovir, they also reduce the activity of these microglia in the brain, which I mentioned just now. So her work is very, very important. Oops, go back one. Oops. There we are. So, where are we at with research? 72 years they've been researching this illness, which is amazing, really. Certainly it goes back to Los Angeles and Iceland and London. They all had epidemics that led to people ending up with chronic fatigue syndrome. So, we're kind of looking back now. In the early days, the machinery or the equipment for doing research was pretty basic. But now, of course, we've moved on to all these sophisticated laboratory work, all the technology, the scanning and everything. Certainly incredible what they are doing now. I mean, I find it mind-boggling. And this field of epigenetics, which now is working out how the genes function, seems to be the clue and the key to getting the understanding of this so-called multisystem illness with treatments that are hopefully going to come. And they're probable, I'm going backwards a bit, but they're probably going to be in the end subcategorising this illness. So you'll say the term CFS is just an umbrella term, and then we've got all these subgroups of different sorts of people. The genes are indicating this, those whose illness is mainly throat and glands and flu-like, those whose illness is a lot of musculoskeletal stuff, those whose illness is very brain-orientated, and so on and so on. So, you've got lots of possible different diagnoses will come out of all this in the end. The things that really stand out, though, are the effects of exercise, the post-exertional malaise, we call it PEM, and the majority of people with this illness find that exercise really, really does sort of wreck them if they push it beyond their comfort zone. My recommendation always is do nothing that makes you sweat, pant or heart race, and you're probably within your capability. Soon as you start pushing it, then you run the risk of serious relapse. So you've got to be very, very careful about exercise. But anyway, I think, the research has really shown us the way, or is showing us the way, and hopefully gradually we'll get more and more in-depth research as the science progresses to give us some very real answers. Now, I'm not sure what comes next. Right, we move on to COVID-19. We'll have time for questions at the end, so we can go back to some of what I've talked about. What about the vaccination? First of all, I won't go into talking about COVID-19 a lot because you've probably seen it on your TV ad infinitum. And, we've all seen the horrible scenes of people dying and burials and goodness knows what. So we do know it kills a certain percentage of people. We also now know that it's likely or possible that it can lead to something that we would here today call ME, chronic fatigue syndrome. This so-called long-haul thing is exactly the same because COVID is a viral illness, and the vast majority of people who have chronic fatigue syndrome will have started with some sort of viral illness. There will be some whose have other causes, but certainly viral illness is almost always the main cause. So inevitably COVID is going to go on to a certain percentage of people having post-viral syndrome, rather like we see after glandular fever. And of those people, let's take glandular fever, maybe 10% of people with glandular fever have post-viral syndrome, but at 3 months, the majority of those people will be getting better, and at 6 months, you're only left with about 1 or 2% who are still unwell. And I think we'll see the same with COVID. We've got quite a lot of them in that post-viral stage, but they'll hopefully get better, but we'll be left with a group who do remain ill longer term. So what about vaccination? Now that's just about to happen. Well, we don't know, do we? It's all a bit, every week they seem to change what they're telling us, but it's going to come and it's happening elsewhere. And I think we're very lucky in New Zealand that we're not launching into it too fast. First of all, we don't need to launch into it too fast if we remain protected. I mean, there is always that little bit of a threat hanging over us, but the threat is minimal and we can protect ourselves up to a point. But we can sit back and wait and see which of these vaccines is going to be the best, which will need 2 jabs, which will work for the old people, which will work for the children, which will be safe in the pregnant. There's all those answers. And of course, we have no idea how long it will last. I mean, we know our flu jab that we get lasts about 5 or 6 months. I mean, people imagine it lasts the whole year right round till next year, but in fact, it lasts us through the flu season. So if we have our flu vaccine, let's say in March, it'll last us through to about August or September, by which time it's spring and the flu bugs are sort of fading away. So we don't know how long the COVID vaccine will last, and we're going to get the issue of, okay, maybe the vaccine lasts for 6 months like the flu one does. That's all right for all of us here, but what about all the people then coming in from overseas who are going to be bringing COVID in at the wrong times of year and that for us? So these are questions we just don't know about. But more importantly, I found that people with CFS want to know about whether this vaccination is going to be safe for them. So first of all, we have to say that if you've got this very busy, overactive immune system, which we know now is likely in the majority of people with this illness, and if the immune system isn't overactive, then they may not have CFS. But let's assume the majority have a very busy, overactive immune system, so you're kind of protected a bit against other infections. And people have often said to me, oh, I knew I was getting better because I actually got a cold this year. That's a bit of a strange thing to say, but that's what people say. And that's because their immune system has begun to normalise, so they're more prone to bugs again. So all the time you've got your ME, the chances are you're going to have a reasonable level of protection. We can't guarantee, but it's going to help. The other thing to say about the vaccine is that it's not a live vaccine. Now, there are 2 types of vaccines, those that are live and those that are not live. And if you have a live vaccine, such as the measles or the hepatitis vaccine, you are more prone to get a reaction to it, whether you're an ME patient or not. If, however, it's not a live vaccine, the risks of reactions are quite a bit less. So that's, a bonus in that most of the vaccines now that we're hearing about are not live. And the other thing to say is if you do get COVID-19, you might get it because your immune system might be normalising a bit, or you might be going through a good phase, so you're a little bit more prone. The reaction to getting the illness might worsen you, make your CFS eventually worse, give you a serious relapse. So, you've got to be very aware of that, the fact that, yes, I am at risk. I am at risk at getting a worse kind of illness. So you've got to be very aware of that. And the other thing, of course, is that like many, many groups of people, there will be always the odd one who gets a really bad reaction. And there will be people with MECFS whose illness actually started with a vaccination. There was quite a big report from Norway some years ago of young teenage girls and women who were given the vaccine Gardasil for protection against cervical cancer, and also the hepatitis vaccine and the meningococcal vaccine. And there were quite a percentage of these groups who seemed to get MECFS as a result of the vaccine. When I say quite a percentage, it was actually a very, very small percentage, but enough to be reported. So there will be people whose illness started with the vaccination. They're the ones that are going to be more worried and probably should be more cautious. But I think anyway, if you are going to go ahead and have the vaccine, which probably is important, you choose a time when you're actually at your best. So in other words, you know, everyone with this illness is a bit up and down. You don't choose to go when you're going through a relapse, or you're not feeling too good, or you've just had some other procedure that's dragged you down a bit, or you've had a recent accident, or there's huge stress going on in your life. You know, you need to kind of wade your way through all that lot and choose a time when you're at your best, and then you should have ideally a couple of days of rest and relaxation in the lead up to the vaccine, and this applies to any vaccination you might need. You have 2 or 3 days rest and relaxation beforehand, and allow a few days rest and relaxation afterwards. That minimises your risk of getting a bad reaction. However, you might still get a bit of a reaction, because all of us are prone to reaction. I had quite a bad reaction to a shingles vaccine last year. My arm swelled up and I felt really quite woozy. So it happens, you know, even to healthy people. And you choose your time for it, obviously, but more importantly, you go to the place where you're going with some medication on hand if you happen to be a sort of allergic type person. It's the people who get hay fever and other allergic reactions who are most at risk of reaction to vaccine. So you've got some antihistamine. Possibly if you've had a bad reaction in the past, you might even carry prednisone around with you, which is a steroid. And if you take those things with you when you go for your vaccination, and then if you start to get a reaction while you're there, and often these reactions begin to come on quite quickly, and they usually get you to wait for 15 minutes. I say wait for 30 minutes at least, maybe wait for an hour, and if you're free of any bad reaction during that time, you're safe to go home. But at least if you're there, presumably in a medical facility, they've got stuff that they can give you, but if you've got your own stuff, you feel more confident and you're well and truly prepared. So that's the story with the vaccine. Who's most at risk? Well, I think, again, we've probably all been taught by now, over 65, any underlying illness. Now, that doesn't necessarily mean MECFS, because, as I say, you've got this overactive immune system, which might in itself be protecting you. But people with things like asthma and heart disease, other lung disease, immune deficiency, which is the kind of opposite of CFS, these are the people most at risk and who probably should be having the vaccination. Bear in mind, it doesn't give 100% immunity. None of the vaccines have been shown to be 100%. So, you know, it doesn't mean you stop washing your hands or do the sort of things that we should all be doing to protect ourselves. The second dose is needed with most of the vaccines, and it may in fact turn out to be all of them will need a second dose, and we've no idea how long it will last anyway. Might last for life. I mean, if you have the shingles vaccine or the mumps vaccine, it's probably going to last you for your life. Might need a booster if you were, going to be particularly at risk in some way. Maybe if you're a kindergarten teacher, you kind of going to have these bugs around much more. I'm talking the measles, mumps and things like that. So, having a second dose of COVID may well be needed. We certainly don't know how long it's going to last. But however, you don't need to be told by now, hand washing, sanitation, masks, isolation. None of us are a metre apart or anything, are we? But hopefully it's not around at the moment. But using the tracer app, I think, is good common sense. So if you haven't used it on the way in, use it on the way out. And that's the book that she mentioned that I've just reproduced. I did the one, what year was the first one? 2012. So we're talking 8 years on. So there's been quite a lot of changes in research and things that have happened. So this is the new edition of the first one. And there's also the teenage one and the pocket guide, which is just a smaller précis of it all, really. And I will say sleep well tonight. You've probably all been done now. So you can put your head down if you want, but if we've got questions, we can have them, okay? Anyone got any comments or questions at all? Yeah, at the back.
Thank you for that talk. I'm just really interested in the severe POTS. I've got a 26-year-old who's been diagnosed by you with very severe POTS, dysautonomia. And just from reading, is there a significant number of those people that actually lack blood volume? I've read 20% loss, possibly, that's quite an underlying.
Right. Well, this lady has asked if you didn't hear maybe to comment about POTS, and she knows someone with POTS, and there's obviously been a lot of talk already tonight about POTS, and she's saying, is it due to lack of blood volume? And POTS is due, it's this postural, woozy, lightheaded feeling. And certainly lack of blood or lowered blood volume is very significant. And many years ago now, I can't remember how many, 30 years ago, Dr. David Bell in America had done a big study on he's a paediatrician, young kids with POTS and chronic fatigue syndrome, and he found that consistently in his group the blood volume was decreased. And this was then sort of, researched more widely. And some people have up to a fifth of their blood volume less than the average person. So low blood volume is certainly part of POTS. And what happens is you've got the low blood volume. If you're standing up, the blood always soaks into your feet a bit. Volume goes down that way because of gravity, and it leaves your brain a bit empty. Now that's really simplifying it, because if your brain was empty you'd be dead, but let's assume that you can imagine the blood volume isn't filling it, so it falls this way a bit. So increasing the blood volume is something that we aim for in POTS, and we do that various ways. Extra salt will increase blood volume, coupled with extra fluid, plenty of salt, and it needs to be all through the day, not just once or twice with your evening meal or your breakfast or what have you, but every 2 hours you have a good helping of salt in some way or another, coupled with plenty of fluid, because you won't retain the volume properly if you don't have plenty of fluid for it to work with. So you need that combination of fluid and salt, and as I said, that American study showed that you also needed sugar as well. And that should be every 2 hours through the day. And then we use the drug fludrocortisone to help the body retain the salt, which keeps the blood volume up. Now, some people, I know a doctor in America who has kept herself free of symptoms really for quite some years. And I mean, it's quite an unusual therapy. She has a weekly infusion of normal saline intravenously. Now, it's quite a dramatic thing to do, isn't it? And I remember way back when David Bell was presenting this work about the young people with the low blood volume, he used to talk about the fact that, yes, intravenous saline will overcome a lot of the symptoms, and a lot of people with ME will feel much better, but there are lots of dangers in regular or even one infusion of saline. You know, you're putting something in the vein. It's all the issues of keeping things sterile, having the right amount. I mean, it's very, very intricate work, not something you trot off to your local GP and get done. But it's, you know, got potential for some people. So some people have a very bad reaction sometimes to their POTS. You know, they might pass out, or something happens, they got very, very dehydrated, and they will be admitted to hospital, and the first thing they do then is give them intravenous saline to boost the blood volume again. So yeah, your answer there, hopefully a bit long-winded, but any other, yeah?
Related to that, how do you measure that the blood volume?
Okay.
My sister-in-law's like this tall and I'm this tall.
Yeah,
So I'm
okay.
blood
Well,
volume.
what they've shown in their research that the blood volume is depleted, and it's extremely intensive research. I think they injected something like radioactive chromium, but it might not have been chromium, but it was a chemical like that anyway, and that somehow or other, with special equipment and special chemical analysis, gave them an answer of what the blood volume was in that person, which could then be related to the size of the person. So it's not a test you can have done easily, but the symptoms of POTS are the lightheadedness if you stand up for any length of time or if you stand suddenly. Many people feel particularly lightheaded in the shower because they're getting hot and their blood vessels are dilating and they're sweating a lot. Sometimes school children standing in a line in the sunshine, one of them keels over. It's a POTS issue. So fainting and feeling very lightheaded if you get up suddenly are the typical symptoms, and the blood pressure is usually very low too. So if your blood pressure is very low, you have quite a rapid pulse because the heart's trying to pump more blood up into the head. Those are the symptoms that people get. Okay, yeah.
If the person has the vaccinations, and both of them, is there another test 6 months, 12 months ahead to find out whether the vaccination is still working?
Oh, right. This gentleman's asked if you have the vaccination. I take it you mean the COVID one.
Yes.
Can we find out 6 months down the track if it's still working? I think they are doing that sort of work. I mean, I don't know enough about it to know exactly what they are doing, but certainly they can test your immunity. I'm not sure how expensive or how difficult these tests are going to be, but potentially it's very possible. Yeah, that's how they're telling now that some of the vaccines are not lasting or not working. They say if you're producing the antibodies in your bloodstream to see whether they're working or not. But it's, you know, it's sophisticated work, but I think because of our scientific ability now, these sorts of tests will become much more readily available and cheaper, hopefully. Any more questions? Patrick at the back.
Have you heard any stories about people who have ME and then they've gone on to catch COVID? And how is COVID affecting them relative to a healthy person who catch COVID?
Okay, so Patrick's asked if I've knowledge of people who've had chronic fatigue syndrome who've gone on to have COVID and how they've coped with it. Well, I have read about some who've gone on and caught COVID, that's for sure. I have had one patient who was an ME patient who actually came from overseas, and she now has long haul COVID. She caught COVID somewhere in transit, and then she had the combination of COVID plus her ME, and now she's suffering the long haul COVID. So, you know, these combinations are perfectly possible. But, you know, again, our knowledge is very, very minimal at the moment. It'll come. The money's there pouring in. Anyone else with a... Yeah.
The medication spironolactone.
Yeah.
What dose?
Okay, this lady's talking about spironolactone, what dose. Oh my goodness, you caught me there. I think it's 0.25 milligrams minimal. That's the sort of lowest dose, going up to about 25 milligrams. But you better not quote me on that, because I don't want anyone to drop dead by having too much. It can be, look up on the internet. That would be the safest thing to do. But it's a pretty safe drug. You know, it's not like a dangerous drug or a drug of addiction or anything like that. Very old-fashioned drug, actually. But I must remember to look that up, else I'll get caught again. Any other questions? Yeah.
Going back to the POTS, if you had orthostatic intolerance, the inability to stand up, would that indicate POTS necessarily?
Right. Okay, well, this lady's asked if you have orthostatic intolerance, which means you stand up and presumably feel very lightheaded, you stand up suddenly. Is that POTS? There are other reasons. There's what they call neurally mediated hypotension, which is a different condition. It's a change in your blood pressure due to the way your brain functions in relation to your cardiovascular system. POTS is due to combination of low blood volume, loss of salt through a lot of sweating, and dilated blood vessels, which again common in chronic fatigue syndrome. Neurally mediated hypotension is a very low blood pressure which can occur often when you're standing, but it's a different mechanism to POTS. Okay, so some people do have one or other or both even. Okay, any other?
Can I ask something? I was diagnosed with fibromyalgia, but a lot of the symptoms are the same as ME.
Yeah.
Is that, connected?
Okay, this lady is asking about the connection really between fibromyalgia and ME. Where are they connected or not? And I think two things I always say to people is a lot of people get diagnosed with fibromyalgia as they do with chronic fatigue syndrome, sometimes both. Two separate sort of things to say. First of all, chronic fatigue syndrome is a definite recognised disease, classified by the World Health Organization and International Diseases Control people and all the rest of it. Fibromyalgia is not a disease. Fibromyalgia is a set of symptoms. The majority of people with chronic fatigue syndrome will have a certain amount of fibromyalgia, if not a lot. And the majority of people with fibromyalgia tend to suffer from chronic fatigue syndrome. So there's this overlap. But you can also get fibromyalgia in other diseases. So it will occur in polymyalgia, rheumatoid arthritis, heart disease, kidney disease, diabetes. All those people can get fibromyalgia because of abnormal underlying chemistry associated with their particular disease. So that's the story. Fibromyalgia is a set of symptoms, and it doesn't necessarily mean you've got chronic fatigue syndrome, but I think about 75% of people with fibromyalgia will have chronic fatigue syndrome as well, and vice versa. So there's a big overlap.
So out of those other diseases or things that you mentioned, if you've got more than one of those and chronic fatigue, how do you separate that to know which is which and how to treat them? Okay,
well this man asks, you could have several of those diseases which cause fibromyalgia and fatigue and what have you. How do you separate them out? How do you treat them? And these sort of very complicated patients are the doctor's heart sink patients, quite honestly. Because if you've got someone with more than one or two diseases, you're straight away into a lot of complexity. And, we're not all specialists in all those areas anyway. So someone might have kidney disease and rheumatoid arthritis and chronic fatigue syndrome, let's say. And you've got to try and separate them out a bit and treat them as individual conditions. but sometimes the treatment for one might aggravate one of the other conditions. And this is where medicine becomes very, very complicated, particularly very, very complicated too in elderly people who end up with lots and lots of different illnesses, seeing lots and lots of different doctors, and they have a pile of pills by the bedside of, they don't know which ones they're supposed to be taking anyway. Medicine is really, really complicated the more people have in the way of different conditions. And you've just got to try and tease them out as best you can. And I think a lot of people with chronic fatigue syndrome end up seeing the neurologist and the endocrinologist and the rheumatologist and the bowel specialists and so on, because those particular specialists are more likely to be able to tease out those symptoms and deal with them for that individual, which then might help overflow onto some of the other conditions. Okay? Yeah.
Just curious about the sympathetic nervous system and how it goes into play with any illness and then doesn't switch off again.
Okay, yeah. Yes.
Yeah.
There's
a curiosity around that on how some people switch off and go back to normal and we don't. Is that kind of like the old-fashioned
Well, I think
approach, or-
this lady's asked about the sympathetic nervous system and the fact that it, is an aggravation, it doesn't switch off, it might overreact. The sympathetic and the parasympathetic nervous systems are sort of systems within systems, if you like. So your whole neurological system is lots and lots of nerves and hormones and chemicals and what have you. And the parasympathetic and sympathetic nervous systems are all part and parcel of that, and they all interact with each other. And a lot of people have problems with the so-called sympathetic nervous system in this illness. The hypothalamus and the adrenal glands and the pituitary gland, they're all linked up, but they can be quite malfunctioning sometimes. And I think, again, a good neurologist come endocrinologist can often sort those things out. They're not always easy to fix, that's for sure. Though for most people with these sorts of things going on in the background, and it applies probably to most illnesses really, getting your sleep right is a real clue to helping improve some of these symptoms. And the chemistry underlying is being understood now much more readily.
Thank you.
Okay. Anyone else? We're winding down, are we? Here we are.
Just a question about the interconnection between multiple chemical sensitivities and MECFS. Is there any more understanding now around that interconnection?
Okay, well this lady's asked what about the understanding of whether there's any connections or better understanding about multiple chemical sensitivity and chronic fatigue syndrome. And I think what we know, kind of separate them out really as two separate things in a way. People with chronic fatigue syndrome have increased sensitivity to lots of things. Oh gosh, that light's bright. Be it chemicals or smells or taste or bright lights or loud noises. So part of the whole chronic fatigue syndrome sort of set of symptoms often will incorporate lots and lots of sensitivities. It's sort of, kind of the way some people's central nervous system seems to work with this illness. And a lot of people have wondered over the years, has it been set off by some sort of chemical exposure? And for some people it does seem possible, and for some people very probable. So I think we can't deny the fact that some people's illness might have been set off by toxic exposure. There's quite a well-known woman in England who fell into a bath of some sort of chemical that she was using to drench her sheep. She sort of fell into it and got, this sort of sheep drench all over her. And she became very, very ill as a result, but it left her with long-term chronic fatigue syndrome. So I think chemical exposure can lead to this illness, or poisoning of some sort. You might have some sort of food poisoning, or other poisoning, some sort of gas or other. So I think we know for sure it can be triggered, but multiple chemical sensitivity is a different kind of diagnosis, again with huge overlap, a bit like the overlap with fibromyalgia, not quite so major, but quite a bit of overlap. And multiple chemical sensitivity are usually people who are highly allergic individuals. They're born with a kind of highly allergic genetic makeup, and if you're born with that sort of genetic makeup, then you're much more prone to become very allergic, or not so much allergic, they're not real allergies, they're sensitivities to chemicals, smells, things that go on your skin, perfumes, what have you. So I think the multiple chemical sensitivity is more of a separate issue, but it commonly does happen in this illness. I think we have to say too that sensitivity and allergy are different. Allergy is like hay fever and asthma, and it's and certain foods and things, and you produce lots of the chemical histamine, and you get the typical reaction, maybe wheezing or rash. Babies with peanut butter allergy, that sort of thing. But you can only be allergic to foreign protein. Sensitivities, however, are reactions to non-protein, and they're a different sort of reaction, and they're not corrected by taking antihistamines, which true allergies are. So they're very different. But, they're common in this illness, both allergies and sensitivities. Yeah.
Getting on to something different, vitamin B12 injections, we've found in the past that they can help boost your energy and feel a lot better. If your doctor does a test and finds that you're in the normal range, should you not have an injection, or can you still have it? Because our doctor has said, no, you're in the normal range.
Okay. Yeah, well, this is something that crops up a lot. This man asks about B12 injections and whether if you're in the normal range on your blood, whether you should be having it or not. And you mentioned it probably helped you before. Well, what the story is with B12, it goes back a long way back. It's a very old-fashioned thing. We've known about B12 for a long time. And the research was done in Iceland. They had a big epidemic of people with a bad flu in Iceland, and many of them remained ill for a long time for various reasons that we now understand a little bit more. I mean, the population of Iceland is only 300,000, but, this was a big event. They were fortunate there to have a doctor who became very, very interested in the chronic fatigue syndrome patients, which they had quite a high percentage. And so he's done a lot of research. He's still around, and we're talking years and years and years later. And he found that the B12 level in the fluids surrounding the brain and spinal cord was very low in B12 in these patients. So he started using B12 injections and found that quite a few of them began to feel quite a bit better. And that sort of research has been replicated since, certainly in Florida, and again more been replicated in Iceland. And they have found that, yes, the B12 level in that fluid surrounding the brain is low, and they've also found that many, many people with this illness do seem to benefit from B12 injections, even though their levels in their blood are normal. So the blood level doesn't really give you any indication of what's going on in the brain. And that's the issue that we're up against a bit. But it's very well known now that people with chronic fatigue syndrome, probably about 70% do benefit from B12 injections, but 30% don't. And we don't know why, really. We're all different, I suppose. But if you are going to trial B12, it needs to be something like 1 a week for 6 weeks, and you don't feel benefit till you've had about 4. If you've had benefit at the end of 6 weeks, then probably a monthly booster for a little while, and then finally a 3-monthly booster for a while. So certainly there's good research to back it up now, and it does seem to work for quite a few people, and it is generally very safe. However, there are two issues to mention. One is it's not safe for pregnant women. They have found that there's a higher risk of autism and things like that in the growing fetus. So anyone who is pregnant should cut back on the frequency of their B12. They can still have it, but not so frequency. And very elderly people, they've done a study quite recently, and it's used quite a lot in elderly people just because, you know, old people seem to get more energy when they're given B12, even nothing to do with ME. But they found very elderly people, some of them die a little bit sooner than they ought to. You know, it kind of seems to increase their risk of dying a bit sooner. I mean, this study's very recent and it may not turn out to be highly relevant, so I wouldn't be kind of panicking or anything. But there does seem to be possibly a link between longevity and, or not longevity, the opposite of longevity, and having too much B12. Okay.
On the B12 thing, there's some people in the MECFS community who are quite sensitive to supplements and sort of can't tolerate quite a lot of the sort of supplements and medications. If you can't tolerate oral B12, would having B12 injections be okay? Because I've spoken to people who are kind of afraid to have injections.
All right, well, first thing to say, this lady asks about whether oral B12 is suitable or tolerable or not, or maybe for some people it's not tolerable. First thing to say is if you're going to use B12 for treatment of chronic fatigue syndrome, if you swallow it as pills, it won't be absorbed very well because you only absorb what your body thinks it needs. And like this gentleman over here said, if your blood level's normal, you're not going to absorb much if you swallow it. So you're wasting your money if you swallow it, unless you're a vegan, when your body doesn't get much vitamin B12 from your food. So that's the first thing to say. The second thing to say is that B12 can be given by mouth, and you do absorb reasonably well with the droplets on the tongue, or little things they call dots that you put on or under your tongue, and that through the mouth you do absorb it fairly well. And the best absorption, however, is from the injection, which basically is forcing it into your body. Okay. Now there will be a group of people who suffer from pernicious anemia. They don't absorb vitamin B12 at all well, and they are lacking a particular chemical that helps their body absorb it properly from their food, and those people have pernicious anemia and they have to be given probably B12 injections for the rest of their life. Okay, does that answer your question? I mean, you did say, are people sensitive to lots of different supplements and things?
Yeah, it was more that, so I know people who've been sensitive to B12, and I myself can't take it orally. I get terrible headaches and other kind of symptoms when I do, and so I've been reluctant to get the injections because I've wondered if I might have
I see what you mean, yeah, well, there are some people who are sensitive to too much B12 in the system, there's no doubt about that, and you might just be one of them. If people are worried about the sensitivity to B12, and it's fairly rare, they can be given about a fifth of the injection, a tiny dollop really, because it's a very small injection, tiny dollop of injection in their arm just under the skin, and just wait and see for sort of 15 minutes. And if it comes up in a bleb or there's a little rash or anything, then you probably should leave well alone. If, on the other hand, you can have a test dose and it hasn't done anything to you, then probably going to be safe. Okay, but it's, you know, some people are very, very sensitive to things, and we have to acknowledge that, really. I mean, you can be sensitive to a Marmite sandwich, you know, it's kind of, everybody has their own individual sensitivities and allergies and things, and often we have no idea till they get a reaction. Okay, yeah.
On the B12, I have been having it taken for quite some time, and I thought, perhaps I don't need it, so I cut it off for about 2 months, and then I was thinking, I don't know what's wrong with me. So I went and had a B12, and it was the same day I felt better.
Yeah. No, well, I think this is what many people say. This lady said that she stopped her B12 injections and she went down and she had another one after a couple of months and she felt better again. So there will be some people it works in a dramatic way, and I think sometimes we're not quite sure why, except it probably is doing something to the fluids surrounding the brain. So we don't always understand. But, you know, there's more and more evidence now showing A, that it's generally safe, and B, it can be beneficial. But there will be some people very disappointed because it did nothing for them. So, you know, you kind of can't say everybody in the room would benefit. Okay, we got one.
In answer to your question, one of Dr. Vallings, Judy, before she left to Australia, showed me how to give myself my B12 injections, and I do it in the thigh. You knock your thigh enough times, it goes dead.
Need a bit of fat there, yeah.
And it really does help.
Yeah, some people do learn to self-inject, and it's perfectly okay to self-inject if you feel brave enough. It's a bit bigger than an insulin injection, but it's certainly perfectly possible. The other thing that I think a lot of people don't realise now is that because chemists are allowed to give flu injections, they've got an injection certificate. They're allowed to do B12 as well because it's not a drug. So your local pharmacist may well be more than happy to do it, may not even charge you. So, you know, worth remembering. Yeah.
You were saying with the flu injection, like, and with the COVID vaccine, that they last 5 to 6 months. Now, I'm opposite. I usually get sick in the summertime, and it was last February that I first got the flu, which after I got diagnosed by you. Would it be beneficial for me to have it at the other end of this?
Are you talking about the flu injection? Yeah. Well, I think.
Because I don't want to feel
I think a lot of people, and not just anything to do with ME, but a lot of people, their flu injection doesn't last very long. Or like this lady says, she gets her flu at the wrong time of year. I mean, that's maybe just the way her body's made. But I have a lot of patients, and I'm not talking just chronic fatigue people, who have a second flu injection. They'll have maybe their first one in February or March, and then they'll have another one in August or something like that, because they've been like you. They've got flu sort of out of season, if you like. So it's perfectly safe to do that if you're all right with the flu injection. Okay. I think we've just about wound down, have we? I will just say I've got Linda, my publisher, here, and we've got the books here if anybody's interested in looking or buying or what have you. If we run out, I'm sure Linda can take names down. Okay, all right. I won't sing a song, I'll take it off.
Just before you go, Ros, and we all break up, I just wanted to say a big thank you from everyone here at ME Auckland. Once again, we're truly blessed to have you in the community and share your deep knowledge, everything you know about ME. I know there's a lot of concerns floating around now, especially about COVID. People at ME are wondering what will happen if they catch COVID. Are they going to be bad off? Is it safe to take the vaccine, knowing that people at ME have developed different vaccines? So it's really nice of you to come out here and provide some credible information and help sort of quell some of those concerns. I would just say that this isn't all that Ros does. I mean, this is one seminar, and she goes around the country doing this to various patient groups and talking to doctors. So what you've seen today is just the tip of the iceberg and just a tiny bit of tremendous work that Ros does in the community. So we could give her another round of applause.
I will say I had a very interesting experience about a month ago. I gave an overnight talk to the patient group in Ireland and online. So it was quite.
I thought it was just New Zealand. So. Island, but it is it's customary. We've got a card signed by
Oh,
Emmy Auckland
thank you.
boards. We've got
Thank you, that's
a
very
little
kind
present,
of you.
a little
How lovely.
bird Thomas, you quite like those. So.
Oh, lovely. Thank you.
And before Roz runs, I'll just say a little word about Emmy Auckland, which is a charity that organises events. Emmy Auckland is Emmy Auckland's charity for Emmys and Emmy Flies, basically. We as a charity, we're focused very much on where the need is and immediate action relief. So, for example, there's a lot of charities out there which are funding research and funding advocacy and awareness, which is great. But our niche is in helping people who need their help desperately today. So we have people on our books who are too sick to go into work and income, they're down to their last dollar, they can't work, and they need somebody to, they're about to run out of money and they say, look, I can't pay my rent, and they're calling capacity, she goes in and advocates for them. We have people who have been isolated by their illness, have been bedbound, 10 years in bed, they've lost all their friends and their family, and that helps them connect to people in the community and alleviates their isolation. And you have people who are struggling with symptoms every day, and find a doctor that can help them, and they will talk some free strategies and doctors they can refer to make their life a bit better and actually get a way out. So I'm proud of the work that Emmy Auckland does, proud of the work that the team does around me. It's really fantastic. And if you enjoyed today's presentation and maybe want to support some of the work that we do, we have this little donation form which over on the table just there. Just you can just say, look, I'd like to make a little donation, and send it to the info at Emmy Auckland. And you can help support some of the great work that Natalie does, and we see about 200 patients a year for raise under service interactions, and it was on part-time hours. The truth of the matter is we need to be about 10 times bigger than we are now to meet the needs of the community. Multiple sclerosis Auckland raises more than $500,000 a year. We raise about $50,000 a year, so we're looking forward to growing, but to meet the need that's out there, we need to be much bigger than we are today. Thank you so much, guys.